Good morning or good afternoon to everyone. Thank you for joining the global webinar on rehabilitation and assistive technology in universal health coverage. My name is Valentina Pomatto, and I'm the Inclusive Development Advocacy Manager at Humanity and Inclusion, a partner in ReLAB-HS. I will be the moderator today. Let me start with some housekeeping information. This webinar is being recorded. Participants are invited to keep their camera and microphone off. International signing interpretation is provided by Adam and Ayesha. In order to view, find them in the list of participants. Closed captioning in English is provided. Subtitles are embedded, but they can also be viewed in the streaming platform. The link is in the chat. Participants are invited to type any questions or comments in the chat box. These will be addressed during the Q&A session or answered in writing. This global webinar is co-organized by the Learning, Acting and Building for Rehabilitation in Health Systems, ReLAB-HS, funded by the United States Agency for International Development, USAID, in partnership with the Civil Society Engagement Mechanism for UHC 2030, the Global Health Council, and Results for Development. This webinar is timely. It comes in the lead up to the United Nations high-level meeting on universal health coverage on September 21st, which will lead to the adoption of a new political declaration on universal health coverage. But it also comes just a few months after the adoption of the first ever resolution on rehabilitation at the World Health Assembly. This landmark resolution reaffirmed that rehabilitation is fundamental for universal health coverage. Universal health coverage means that all people have access to the full range of quality health services when and where they need them without financial hardship. It covers the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. The global needs are huge. 2.4 billion people globally need rehabilitation, and 2.5 billion people need assistive technology. However, financial coverage of these services and products, including via social protection schemes and health insurances, remains variable and poor or even absent in many low and middle-income countries. As a result, rehabilitation and assistive technology represent, for most people, an unbearable out-of-pocket expense, with significant consequences on access. More than 50% of people who need rehabilitation cannot access it. Access to assistive technology varies by country between 3% and 90%. So today, we want to make the case for the integration of rehabilitation and assistive technology in policies and mechanisms for universal health coverage and highlight some examples of these efforts. We will do so with our distinguished panelists. Andrew Mubangezi, Assistant Commissioner at the Disability and Rehabilitation Division, Ministry of Health, Uganda. Eliana Monteforte, Director, Special Projects at the Global Health Council. Kylie Shea, Team Leader for Assistive Technology at the World Health Organization. Nishta Shrestha, Deputy Chief Physiotherapist at the Ministry of Health and Population in Nepal. Tamara Srisate, Program Director at Results for Development, and Sophie Tudiok, member of the advisory group of the Civil Society Engagement Mechanism for UHC 2030. Thank you for the panelists for being with us today. Let's start with the first topic of discussion. Many policy frameworks recognize rehabilitation and assistive technology as part of universal health coverage. But what are the challenges and the potential solutions to translate this formal recognition into tangible actions? And what are the barriers resulting in limited coverage of rehabilitation and assistive technology, in particular in low and middle-income countries? I ask Kylie Shea from WHO to reply to these questions. Thank you very much.
So thank you very much for the opportunity to speak to the forum, and also thank you for the question. Now, I just want to set the scene for my answer, because I am the team lead for access to assistive technology at WHO. And so my response will be weighted towards assistive technology in its broadest context and considering the 6 functional groups of products, and also using the term assistive technology to refer to the products as well as the systems, services, and the
I'm sorry, we would ask participants to mute so to avoid background noise. Thank you.
Okay.
Sorry, Sally, please go ahead.
I just want to flag, when I use the term assistive technology, I'm using it to refer to products as well as the systems, the services, and the policy environment needed to ensure effective access. So I just want to flag in terms of these policy frameworks. 5 years ago, the World Health Assembly adopted resolution WHA 71.8, which embeds access to assistive technology as an integral component of universal health coverage. And of course, just this year, we've all celebrated the first resolution on rehabilitation, highlighting the complementary role of assistive technology within rehab. Now, the assistive technology resolution called upon WHO, amongst other obligations, to prepare the first global report on assistive technology. Now, that was launched last year, and the report provides some really quite startling insights about the need and the unmet need for assistive technology. And it also partly answers the question regarding the access barriers that people face. So I wanted to share the statistic that's already been highlighted, that 2.5 billion people need assistive technology, and that number is expected to grow to 3.5 billion by 2050. But at present, there is not enough system and human resource capacity to meet this need. And that means we have this significant inequity of access between countries and settings. Also, the report shows the largest group of assistive technology users are older people. So 2 in 3 of people aged over 60 need at least one assistive product. And yet this group does not fit the profile of those that are most actively referred to or participating in organised rehabilitation in many countries. So they're often overlooked. Also, the majority of people accessing their assistive products are accessing them from private shops or clinics, and they pay out of pocket, which is not part of the principle of universal health coverage. So an estimated 67% of people are not benefiting from support through competent personnel when selecting, fitting, or using their assistive products, which has associated risks, and those who cannot afford to pay are missing out entirely. And finally, we have this barrier of distance to services, and that is exacerbated by a continued tendency to centralise access to services at tertiary level. So considering these statistics and the barriers, I will shift gear to some solutions or some suggested solutions. So we need to increase our focus and advocacy in support of access to AT as part of universal health coverage. But we have to ensure that our efforts are inclusive of the 6 functional domains of assistive technology, and that we are integrating access not only in the context of rehabilitation, but also across the whole health system, including in prevention, palliative care, and long-term care. So to do this, I can offer a few strategies, but this is not all, but these are a few highlights. Firstly, we need to think about increasing awareness and understanding of assistive technology, and this refers to rehab as well, across the whole health workforce. So it becomes routine in the case of assistive technology to perhaps identify the possible need for a hearing aid for an older person attending a routine health check, or early identification of a child that could benefit from cognitive assistive product if they're struggling at school. But this needs broad awareness across the health workforce for this identification to occur. We need to recognise, in particular, primary healthcare as the frontline for health services. And that means empowering primary health workers through competency-based training, adequate facilities and supplies to not only identify and refer, but also to provide on the spot those assistive products that can safely be provided at this level of healthcare. And in particular, and linked to the above, we have to respond to the growing and urgent need for timely access to AT for older persons. We need to reduce access barriers, such as embedded requirements for assessment and prescription only by higher trained personnel, because this system is failing as it is not feasible to keep up with the demand. Rather, we can work on protocols that enable safe provision, referring only those with identified risks and reducing the barriers. And finally, I just want to highlight the potential to harness the power of digital technology, not only just innovation within the products themselves, but as a tool to improve service delivery, including through smart assessment tools, which can reduce service delivery time, and also reducing distance barriers through remote consultations. Thank you very much.
Thank you. That was very straight to the point, but with very important key messages. And I would like also to hear another perspective regarding this first topic of discussion. So I would invite Ms. Shestra, Deputy Chief Physiotherapist, Ministry of Health and Population from Nepal, to take the floor and provide her point of view in regards to these guiding questions. Thank you.
Namaste. Thank you, Valentina, and thank you everyone for joining today. I will be focusing my discussion from the perspective of Nepal. So as we know, Nepal is a landlocked country and it's in South Asia region with approximately population of 30.3 million and has a federal system of governance. We do have various policies like National Health Policy 2019, Public Health Service Act 2018 that has prioritized rehabilitation and assistive technology, and it's also integrated in general health services. In Nepal, we are progressing towards the universal health coverage, and the Universal Health Coverage Index has progressed over the years, and it was scored 20 in 2000, whereas it's doubled and it's 53 in 2019. Focusing on the rehabilitation and ET activities in Nepal, based on Rehab 2030 and ET 2030 initiatives, various toolkits has been adopted in Nepal, like situation assessment of rehabilitation, National Rehabilitation Strategy Development Guide for Rehabilitation Workforce Evaluation, training for assistive products, as Kylie mentioned, to take the training and take the assistive products to the primary healthcare center level, priority assistive product, the rapid assistive technology assessment. And we would like to thank our stakeholders and partners actually with whom we were able to make this possible, especially USAID, WHO, and Handicap International. However, in Nepal, approximately 90% of the rehab service still, it's been provided by the private sectors, and it's largely uncovered by the benefit package. We find challenges and potentials at multiple levels. Focusing on the leadership and governance perspective, in Nepal, leprosy control and disability management section is the focal unit for implementing activities related to disability management, assistive technology, and injury preventions, plus the leprosy. But we believe there must be a separate entity leading to, which will lead related to rehabilitation and assistive technology in the health system, considering its massive need at the population scale. Talking about the provincial and local level, we still need to integrate rehabilitation and assistive technology at that point. Talking about the coverage of the rehabilitation service, there is large unmet of rehabilitation service at all the level of the healthcare in Nepal. As we know, based on the pyramid of the healthcare service delivery, a large number of service receiver is at the PHC level, and we still need to integrate rehabilitation and ET at the PHC level. We also need to integrate comprehensive rehabilitation service at the tertiary, secondary, and specialized hospital with good quality service provisions. So there's some solutions that should be implemented. For integration of rehabilitation at the PHC level, we need to adopt task shifting approach like how we are doing in Nepal. We have started training health professionals and healthcare workers related to the rehabilitation service based on the data from the WHO Rehabilitation Need Estimator. We also have advocated with the healthcare system-led leaders to establish a comprehensive rehabilitation setup at the tertiary and secondary level. And the quality of service delivery can be improved through generating few guidelines, protocol, and quality indicators, which we have developed few guidelines and protocols. There should be a continuous professional development and enabling environment for the rehabilitation professionals. And about the research and evidence generation, there should be a proper evidence generation at the country level by collaborating with academics, institutions, development partners, and the users group. Not forgetting about the community level linkage, there should be a strong linkage between the primary healthcare givers and community workers and the volunteer. Talking about the financial aspect, we do have a social security protection scheme, which is in line with the universal health coverage. The basic health service package, which is the benefit package for the primary health care, and that still needs to integrate rehabilitation. But we have national health insurance, which includes physiotherapy, speech therapy, and 21 assistive products in the list. We do provide conditional grants, tax exemptions for the fabricated assistive product, and we are implementing public-private partnership, but we still need to expand provision of the rehabilitation at the PHC level, mostly utilizing low cost and high yield interventions. We also have to integrate rehab and AT at the basic health service package, which will be implemented at the primary level. And there should be a wide spectrum of different rehabilitation service at the national health insurance level. The insurance health scheme is in revision phase, and we are continuously in the advocacy phase. Focusing on the human resource, it's similar with the global perspective. In Nepal, we do have a critical shortage of human resource. And most of the human resource, approximately 71% is, as mentioned in the STARSH, this was conducted in 2018, is in the urban area, mostly on the capital city. There are inflows of rehabilitation workers, but the efficiencies are limited because of the poor financial initiatives as well as the limited infrastructure. However, we do witness some good progress at the provincial and local level. Provincial and local hospitals have started recruiting rehabilitation professionals, and other great achievement in the far west region of the Nepal, the provincial government, in support of USAID physical rehabilitation activity, which is managed by Handicap International or Humanity Inclusion, is catalyzing the establishment of prosthetic and orthotic department, which will help for the service provision as well as human resource utilization. So in conclusion, recognizing rehab and assistive technology as a part of universal health coverage is essential. And there should be a collaborative effort among the stakeholders to overcome all the challenges that we faced in different level. And we need to ensure equitable access to the basic health service, including rehabilitation and assistive technology, as mentioned in our policy document. And thank you, everyone. And thank you for inviting me to discuss in this panel discussion. Thank you.
Thank you very much to both panelists who kindly replied to these first questions under topic number 1, and providing an AT and also a country level perspective. We now go to the second topic of our discussion today. Universal health coverage is high on the global agenda with the upcoming high-level meeting on 21st of September. But what is the place of rehabilitation and assistive technology in the current status of the UHC debate? And what are the levers to increase political attention on rehabilitation and assistive technology equally to the other components of the UHC continuum, which are prevention, promotion, treatment, and palliative care? I would like to ask to reply to these questions to Sophie Tu Diop, as advisory group of the Civil Society Engagement Mechanism for UHC 2030. Sophie Tu, the floor is yours.
Thanks a lot, Valentina. Good morning, all. Good afternoon. As Valentina said, my name is Sophia Chidiop. I am an advisory member of the Civil Society Engagement Mechanism for USC 2020. For everybody, the CISAM, the Civil Society Constituency for USC 2020, and a global multi-stakeholder movement for universal health coverage. And at CISAM, we convene civil society organization voice to ensure that USC policy are inclusive and equitable. Coming back to the topic, I just wanted to highlight the fact that rehabilitation and assistive technology as an essential part for universal health coverage, but also on the ground, what we see is there is a lack of awareness and information, financial and cultural barriers that are really a key reason for not seeking or receiving rehabilitation and assistive technology, as really include this as key component for USC in general. And what I just wanted to highlight that is rehabilitation and assistive technology has not been really integrated, into the health pyramid in developing countries. I'm living in Africa, mainly in Senegal, where I live and also where I work. But if I look at what happens on the ground, there is that few programs that integrated rehabilitation or assistive technology as a major access to ensure universal access to basic health care, And the most compiling example I have is really related to neglected tropical disease, which really continue to disproportionately affect the poorest members of the global community, mainly in areas where they don't have access to water, to sanitation, but also to basic healthcare system, But I think there is time for us to really think deeper, on what rehabilitation and assistive technology means for us, Do we have the same understanding at global level, at regional level, but also at national level? Why it's not really included in the health pyramid in low-income countries? And I think we really need to step back, and think more on that. And perhaps if we do that, perhaps we will have more results, And also there is a need to concretely think on how to integrate rehabilitation into existing health development plans. It's one thing to have all of this agreement that we have at the global level, but also at the regional level. But the work it's mainly at the country level. And in order to move forward, and ensure that it's included and it's part of our discussion, there is a need to have budget for treatment, but also to have budget for rehabilitation, And I think actually we have many opportunities, And the main opportunity we have right now to increase political attention on rehabilitation and assistive technology is a United Nations high-level meeting on USC that will take place on September 21, as Valentina already said. And I think during this meeting, we will have, leaders will agree on concrete commitments that will shape, the USC agenda for many years to come. And it's time for us as civil society organization, for example, to make the case and ensure that rehabilitation is mainly included, on the overall discussion. It's also important to highlight the fact that negotiation on political declaration are now in final stage. And through this process, we started in May, the Civil Society Engagement Mechanism for USC. We have worked closely with civil society groups, at both regional, national, and regional level. And with our colleague, for example, Smita, I think with online, we really work to ensure that the final political declaration include strong language on assistive technology and rehabilitation, And as we see, the last version will contain, strong languages on assistive technology and rehabilitation services, which is really great, In terms of levels, at the national level, I think there is a need to put an emphasis, on key main points. The first one is research and evidence, because as we all know, robust research and evidence demonstrated the positive impact of rehabilitation and assistive technology. And I think policymakers, at national level really need to have some highlights, and some data in order to see why it's important to prioritize, rehabilitation into the overall healthcare system. The main key point is linked to policy integration. because in reality, as I said earlier, if you look at the overall health pyramid, in low-income countries, you will realize that we have prevention, we have treatment, but there is most of the time no mention to rehabilitation. But if we have mentioned, they do not go deeper. And if you look at the strategy, we really have nothing, And I think there is really a need to increase the political attention on rehabilitation and assistive technology, equally to other components of USC continuum, in order to ensure that it's aligned, for example, with the Astana Declaration that really highlighted the need to include rehabilitation on the overall primary healthcare system. We also need to put an emphasis on capacity strengthening. And for capacity strengthening, it's not just only for the health workers, or for the decision makers, but also for civil society organization, because we cannot have this concept, in global, included on policy documents, if civil society organization does not work, with policymakers and other actors like private sector on the ground, in order to ensure that it's included. And for that, we really need to build their capacity, in order to ensure that they can, for example, the health workers can deliver rehabilitation services, but also civil society organization can really support. One of the things also is in terms of putting in place financial mechanisms that are really aligned with country priorities, and with country realities. And I think also there is a need for policymakers to explore various financing mechanisms, such as insurance coverage, subsidize, in order to make rehabilitation and assistive technology more affordable and accessible to all. But also, lastly, I think there is a need to have advocacy and strategic partnerships. And what does it mean in reality? We really need to ensure that we involve international organizations like World Health Organization at the table. We invite them at the table. We also include civil society organizations, private sector, community actors, in order to ensure that we can think more broadly on the concept and ensure at the end of the day, it's really included on that. And in order to do that, there is really a need to have this integrated approach of on health, just in order to conclude, I think there are many opportunities to engage and influence USC discussion at global and regional levels, to continue drawing attention to the need for rehabilitation and assistive technology, including the G7 meeting, the G20 meeting, World Health Assembly, Africa Summit. I know in Africa we have actually the Africa Climate Summit, and I think all of these events are really an occasion, for us, as actors, to ensure that we continue to move forward with this discussion, and also we have concrete decisions that will be taken and that will be implemented on the ground. Thanks a lot, Valentina.
Thank you, Sophie, too. I now invite Tamara Shiharazde to reply to these questions. And I'll add the slides that come with your presentation.
Okay. So thank you very much, Valentina, and thank you, my esteemed co-panelists, for setting the stage up and discussing very important issues that I want to build on a little bit through my comments. So first of all, yes, of course, rehabilitation and assistive technologies need to be at the heart of universal healthcare debates. We know that UHC is a means to an end, the end being the goals for good health and well-being for the population. And we know that well-being and good health go beyond things like being cured of a disease or preventing a disease. We cannot achieve well-being without having a population that is productive, fulfilled, and functional in their environment. So definitely rehabilitation and assistive technologies need to be integrated in the continuum of care for universal health coverage as that essential link that moves us from saving lives towards ensuring the prosperity of these lives. Now, the one lever I want to discuss, whom I alluded to already, is the importance of health financing and health finance as a lever to not only progress towards achieving universal health coverage, but also elevating rehabilitation on the agenda and the debate for universal health coverage. Now, why health financing? Two main reasons. One is a very clear that it provides financing and coverage for population to access the rehabilitation services and assistive technologies they need. But two, and arguably more importantly for the topic of our discussion here today, is that integrating something like rehabilitation or any health service in health financing, especially if this is a public health financing mechanism, inherently puts it on the policy priority agenda in the country and globally, and puts it as an important point for universal healthcare debate. Now, the three main issues I want to discuss here when we considered rehabilitation in health financing for universal health coverage are one, the integration of rehabilitation services in health benefits packages that are financed. And this is important if it's not already integrated at the country level to get that foot through the door. Even if we start with just a few services or just a few conditions, putting rehabilitation on a map through health benefits packages, and then strategically spending money for rehabilitation will open that door significantly over the years to come. And the country of Georgia is a good example here, whom our organization, Results for Development, and the Health System Strengthening Accelerator Project is supporting to integrate rehabilitation in their universal healthcare financing program, where just in the last November, they started financing adult rehabilitation services, a very limited package. And less than a year later, there's already discussions in the country of expanding that package and putting in place other resources that support the coverage, such as standards, guidelines, expanding services, expanding human resource capacities, and so on and so forth. The second issue I want to bring up is the importance for us on the health side to figure out how to work and collaborate with all sectors and institutions involved in financing rehabilitation services. So if a rehabilitation is suddenly prioritized in universal health coverage in the health sector, does that mean that other sectors like defense, education, social protection, insurance schemes for disability and accidents, and other mechanisms financing rehabilitation, does that mean that they have to pay less attention or deprioritize it? Well, of course not. We need to work together. We need to collaborate and coordinate with all the actors, not just to expand coverage and make sure there's universality in coverage, but also to join forces for the needed advocacy to elevate rehabilitation on the UHC agenda, not just in the country, but also at the global level. And last but not the least, I want to highlight the importance of strategic use of funds when we are financing rehabilitation services. For three main reasons. One being that there cannot be universal health coverage without strategically using the limited funds that we have and figuring out what services are we funding with which providers for which population groups, how, and so on and so forth. Two is that the strategic use of funds will help us create high quality services and better meet the population needs. And the unmet need is out there, and this is a potential for generating huge demand in the population, and the demand in the population translates very often to establishment of this service on the health policy agenda at the highest level. And last but not the least, well-used resources make a very good case for advocacy and opportunities for even additional resources going into this field. So I will end here, but I would like to highlight a report coming out, a collaboration among Results for Development and World Health Organization that discusses these issues in even further detail. If you could switch to the next slide. And my colleagues will also insert a link in the chat. So a report is called Rehabilitation Health Financing and discusses these issues in further detail. It is in final design stages for publication. So if you follow this link, you can sign up and give us your contact information. If you're interested, we will send it directly to your email as soon as it is published. So thank you very much, and I'm happy to take additional questions if there are any.
Thank you. Thank you very much for the two panelists to reply. I invite participants to type comments and questions in the chat as the Q&A moment approaches. We go to the third and last topic of our discussion today. In order to reach universal health coverage, health systems must be oriented toward the primary healthcare approach. So the questions are, what are the overall benefits when rehabilitation is integrated at the primary healthcare level? And what are examples of effective integration of rehabilitation in primary healthcare? I'm pleased to give the floor to Andrew Mubangezi, Assistant Commissioner, and he works at the Ministry of Health in Uganda. Thank you. The floor is yours.
Thank you, the moderator. Once again, Andrew Mubangezi from Uganda, Ministry of Health. And again, I have to cross-check whether I'm loud and clear. Can you say whether I'm loud and clear?
Yes, we can hear you perfectly.
Okay. As far as this question is concerned, of course, we have heard that the universal health coverage is key, but as far as the primary healthcare level is concerned, universal health coverage has not been integrated. There is no integrated rehabilitation and AT services at the, that level. First, for Uganda, we are in the initial stages where we have started on the pilot to have the networks of care as a pilot in the regions of the country. Of course, supported by ReLAB-HS, we have established 4 networks of care whereby we are trying to pilot the basic rehabilitation package, the clinical resources manual under the WHO protocols, and we're actually starting. So to go to the question in this regard, the benefits, indeed they are, and one of the benefits are actually the benefits align with the prevention, promotion, timely treatment, rehabilitation, and easy access to all these, including the palliative care, including AT in general, and all the rehabilitation services. And when it is integrated, that is number 1, it is access, and number 2, it enables comprehensive rehabilitation services. Number 3, it reduces costs, because once it is integrated, that means that we don't need a special arrangement, special funding, and actually the resources within different departments of the hospital or the service unit, they can complement each other. And at the same time, based on our model whereby we are implementing the basic rehabilitation package, it's not only typical rehabilitation health experts or professionals who are to offer this integrated rehabilitation services. It is all health workers, could be nurses, clinicians, could be midwives, could be medical officers. So we are trying to orient them into this basic approach to providing rehabilitation and AT services at such a level. And in this regard, actually we expect to accrue many benefits, like the turnover for the services will be high, limiting the complications, and also overall the outcome of intervention, which will lead to the quality of life to the people who are receiving the services. So I may not be specific on what are the examples of effective integration. I think maybe little I can say here is that when we orient, or when we bring on board all the health workers, which we call interdisciplinary approach or collaboration, I think that's a good example of effective integration. Then also, the effective integration in specific to it is that the normal medicines and supply chain, including the AT supplies. So we are also, in this way, we're also in Uganda trying to pilot this with our national medical stores on the entire chain of AT procurement. And in this way, we actually want to train the health workers to build capacity in understanding what we need in respect to AT, understanding the procedure to requisition, and then storage, and even maintenance for the rehabilitation professionals. In that, once the national supply chain is ready, then people can be able to maintain the processes. So if that is not taking much time, I would stop here. Then I may be able to accept any questions related to this. I thank you.
Thank you very much. That was very nice of you to share some insight from Uganda. And I will now ask Eliana Monteforte, Global Health Council, to take the floor and
thank you.
This topic of discussion.
Yes, thank you so much. And I know that we don't have a whole lot of time and we want some time for questions. So I'm going to try to be quick, especially since my colleagues already made some really great points that I was going to make. So I will try not to be repetitive. My intervention is going to take us to a little bit more of a macro level. I'm going to start by talking about UHC and how it links to primary health care. So universal health coverage guarantees that all people, no matter their disability, race, income, education, sexual orientation, etc., have access to health without suffering financial hardship, and that includes rehabilitation and AT services. So to achieve universal health coverage and ensure that all people have access to rehabilitative care they need, Global Health Council, in collaboration with UHC 2030 and other partners, are strongly advocating for governments to reorient their health systems to primary health care. So when we say primary health care, what do we mean? So primary health care is a whole of society approach to health, and it aims to ensuring the highest possible level of health and well-being and their equitable distribution by focusing on the people's needs and as early as possible along the continuum of care. So when we talk about the continuum of care, we're saying promotion, prevention, treatment, rehabilitation, and palliative care. And really key to primary health care is that it brings these health services to the people's everyday environment. So how does that benefit rehabilitative care? Well, first, primary health care ensures that people receive quality, comprehensive care So as I mentioned, rehabilitative care and AT services are included in that, and it brings it as close to the people as possible. So makes it accessible to the people. The other benefit is that PHC is the most inclusive, equitable, and cost-effective, efficient approach to enhance people's physical and mental health and social well-being. So it's not enough to just offer rehabilitative and AT services if it's not reaching the people who need it the most, if it's not reaching the most vulnerable and marginalized populations, and PHC can really help expand and broaden that reach. I'm going to talk a little bit about the pandemic and how that affected rehabilitation and AT services and how PHC could be a solution to that in the future. We saw in COVID-19 how we urgently need universal health coverage. And we also saw enormous disruptions in health services, including rehabilitative health services. And that was caused either because of lockdowns, because resources were being diverted to COVID-19. But if we have strong PHC systems that are made for and by the people, this can really ensure that health systems are resilient in health crises like the COVID-19 pandemic. And we can make sure that people, even when we're in a public health emergency, have continual rehabilitative and AT services at their fingertips when they need it. This is extremely important since coming out of the pandemic, we have seen an increase of NCDs, of non-communicable diseases, many of which require rehabilitative and AT services. And so making sure that we have primary healthcare systems that can address those needs will be incredibly important. And I'm just going to end with a few calls to action to governments that we as Global Health Council have really been pushing. So to realize primary health care and ensure people to have the rehabilitated and AT services that they need, we need leaders to become political champions for UHC and PHC. So that means strengthening and financing comprehensive, essential health care and basic packages of health, and that these are based on epidemiological and disease needs, that you're prioritizing primary health care as a foundation for health services, UHC, and health security. And we're also asking governments that they implement policies, laws, and regulations that allow for integrated PHC services. So this includes adopting and integrating frameworks that strengthen PHC institutions, that support the workforce and those ecosystems. And then, of course, we're also asking for governments to please increase their financing for primary health care to strengthen those PHC services and scale up those PHC services, which include rehabilitation and AT services. That's it for me, and hopefully that gives us enough time for questions.
Thank you very much. Thank you, Eliana, and all the other panelists that kindly shared with us their perspective and insights. I think that we have at least one question that I already saw in the chat, that it's about more concrete examples of rehabilitation in primary health care to really get into the more operational and practical aspects of this work. I wonder if Tamara Shihazde would like to share maybe also experiences from Results for Development, knowing that this is also work in progress at your level. If you might provide just a 1 minute insight on this, if you wish.
Yes, of course, and thank you. So our project is supporting the Ministry of Health in Ethiopia to integrate rehabilitation service at the primary healthcare level. And it's at the beginning stages where there are still discussions on what are the rehabilitation services that can and should be accessible at that level, and how do we move forward from here? What are the opportunities to link this and integrate this within the existing health system structures and levels? So I will stop here and see if there are any insights here, but questions on this, but that this is one of the starting points of promoting rehabilitation on the UHC agenda and ensuring that the coverage is there. And it's one of the more strategic decisions that any Ministry of Health can make to expand the access to the service.
Thank you very much, Tamara. And there were also very good points raised around the need for data for research. And maybe just digging a bit more into this topic, I would like to ask Ms. Kalish Hay to tell us more about how important it was to have recent and very accurate data on assistive technology. I recall the global report launched at the beginning of this year on assistive technology. How did it change? Do we really have good data to move forward with political attention and further integration in universal health coverage? How did that help?
Thanks, Valentina, for the question. And yes, I remember the launch, and I remember the words of our Assistant Director General at the time. She said, "Measure what you treasure." And I think about that often in the work that we're doing in the AT team at headquarters, which is all about, it's not all about, but one of the key pieces of work that we are doing is strengthening and streamlining the tools that we have available to support member states and our civil society partners to better measure and understand the population need. In terms of the importance, it's been an absolute game changer. Being able to represent in the global report the data set that we gathered with the support of member states and actually many of the partners on this call, that has really provided us with that strength and the conviction and the surety around the scale of the need, as well as having some of the data that gives us really good evidence of the top barriers. And I presented earlier, one of the top barriers was the fact that 67% of people are accessing assistive technology through private shops and out-of-pocket payments. And being able to present that and show that within then all of the work that's going on around health system financing and some of the great work that's been presented here, we can show the urgency of that and why that really, really matters. I think just quickly to finish, it's important not to just be looking at the numbers of how many people need assistive technology, but we need to measure the gap. So how many people have and how many people do not have, which is something that we can do with the population-based survey that we developed for the global report. But we also need to be measuring the system preparedness, which is another piece of our data collection toolkit. We need governments to be measuring themselves against progress indicators, which we are doing every 4 years in partnership with member states. And we need to measure the impact of access to assistive technology, because with that, we then are able to again strengthen the political will to provide support for this area of service delivery. Thank you.
Thank you very much. And I think there's also another question for you in the chat, which I don't know if you would reply to it in writing. Is there any list of assistive technology products? And what are the outlined services for rehabilitation? Because there was also another question for the national level insight. So if you can reply in writing, maybe.
Doing it.
Thank you very much. So just I will ask to reply in really quickly in 1 minute to Ms. Mubangezi and Ms. Shestra. What does trigger change at national level, in your opinion? If you could just summarize within a very simple point, what would actually encourage this change to happen at the national level so that decision makers are convinced that rehabilitation and assistive technology deserve a place in universal health coverage. Please, if you can, you both, one after the other, take the floor and be very concise about this. Thank you. I will invite Andrew Mupanzizi to.
Kindly, I beg your pardon in that question. It didn't come through clear.
The question would be, what does trigger change at the national level? What would convince decision makers at the national level to integrate rehabilitation in universal health coverage? If you can just say the one thing that for you would really be influential.
All right. For me, what would trigger, or maybe actually, it's not an obvious thing, but the turnaround when more people turn up for the services, and when they are registered in the health information system, and when the reports are high, normally it is what awakens the policymakers or government, and that is related to demand. So if we set up any service of this nature, ensure that you cause demand to be seen, or demand to be in place, in that there's that concerted show of need.
Okay, so it's really the demand-driven services. Yes. Are the most important and convincing. Yeah. And is there anything you would like to add on this, Ms. Shrestha, about national change? The one thing that would really be game changer?
Yeah. As we know, for the universal health coverage, and we also know there is an increase in non-communicable disease, aging, injuries, and we do have data that there is a huge burden caused due to all of this problems or situations. So the government needs to mostly focus on the universal health coverage and provide the benefit service, include rehabilitation in the benefit service package, and reduce the out-of-pocket expenditure. And the most important thing that we need in context of our country is awareness among the health system leaders, and among the since we have federalizations, there is awareness in this central or federal level, but at the provincial and local level, where we are planning to implement rehabilitation at the PHC level, we need to increase awareness at that level. So if we do that, that might be the game changer. If we focus more on the local government perspective and provincial government perspective for implementation of rehabilitation and assistive technology. So that would be the main game changer.
Thank you for sharing this point. The webinar is going to end. I really thank everyone for being with us today, our distinguished panelists, the co-organizers, and all the participants who joined and contributed to the discussions. Thank you very much, and we look forward for a very powerful UHC political declaration with strong references to rehabilitation and assistive technology. Thank you, everyone.
Thank you.
Thanks, bye.
Thank you, bye.